Good afternoon, everyone. You've all been very attentive for a long day. This is not quite going to be mother case scenarios, more talking about pediatrics and what we need to think about. And as I said, it's a work in progress. So right up, this isn't perfect. We're not there yet. It's just interesting to note that in the beginnings, it was a toddler. It was a child who started this all off. It was an 18-month-old male toddler in an isolated forest village who became ill. And a few days later, he died. Then his sister died. Then his pregnant mother had a miscarriage and she died. And then, interestingly, a house guest that was with the family returned to Sierra Leone, sorry for the typos, and died. And that was all in January last year. And now, 11 months later, we've got more than 13,000 cases and 4,500 deaths. So from a small forested area in Guinea, to think of the man-hours that are going into this across the world, it shows that our world is a very small place. And while some of us might feel that we're preparing for this and it's never going to happen, what I really hope is through all of this we will be able to carry on the standards and the recognition of the need to be prepared to deal with what comes next, because there will be other things, one after the other. So children are a smaller part of this problem, but form probably some of the most poignant photos in it in terms of children being left essentially to die on the street. It's adults primarily who are affected. If we go back to the earlier outbreaks in Zaire, although more than 50% of the population were less than 18 years of age, so you might have expected the majority to be in that group. In fact, only 9% of Ebola virus disease cases were less than 18 years. And in this year's outbreak, it's very hard to glean information on children because people are categorized either up to 21 or even less than 40. But in the Guinea, in one of the publications, only 18% of cases were children. And in the WHO response article, it was 13.8% who are less than 15 years of age. So children are relatively spared. And again, this comes into the epidemiology and the modes of transmission, in that children aren't involved in general in the cultural practices of burial procedures. It's adults who take care of sick people. And so the children have limited contact with those who are poor. And one of the striking features when you kind of drill down on the data is actually how low the risk of household transmission is relatively for susceptible people. If you compare that, say, for example, to something like chickenpox, if everyone was susceptible, you'd have a 90% attack rate. This is down at less than 20%. So it is very unlikely that we will see children who are infected. What makes it difficult, of course, is the manifestation: fever, headache, myalgia, abdominal pain, which then take a few days before progressing to vomiting and diarrhea, and very rarely bleeding and bruising. But they're the same things that come in with children. So if you have temperature of 38 degrees, that's going to be very common. I suppose the biggest benefit for us was having Nigeria taken off the at-risk list. So it's very important that we're really focusing on an exposure history with travel history or particularly direct contact, and that will be unusual in children, and of course within the 21-day time frame. And this just looks at the age distribution in one of these publications, and you'll see that actually the younger children were at the lower group. In this, there was about 20% of cases who were less than 16 years. But when you drill down on that again and try to see, well, what are the outcomes for children? It's very variable. Overall, it seems that the youngest children might do even more poorly than adults, but taken as a group, young people, if you go up to 0 to 20, do better than adults. But overall, case fatality rates have varied anywhere from about 43 or even down to 37% up to 75%. So what do we do? What should we be thinking about as healthcare workers? Well, a high index of suspicion if there is travel and exposure history within the 21 days, and refer to the risk algorithms for that, bearing in mind that most of these cases will have something else, either a tropical disease such as malaria, measles coming back, or typhoid. But I suppose the thing we're all worried about is the child that comes in with overwhelming sepsis and we all stand back and don't treat the child for sepsis. Could equally be meningococcal infection. So we really want to make sure that we're not missing a treatable, easy disease. Well, not easy, meningo is not easy, but you know what I mean. So we need to think about and appropriately treat other potential causes. So what happens when parents and child from an endemic country present? We've had a few scenarios really before Nigeria got taken off the list. And although at the time our PPE donning was not what we would do today, it was probably perfectly appropriate for the situation and for the risks that were actually involved. All EDs should have a designated area and have their PPE available, and as you know, that those revised guidelines are going to come out with the SOPs or the algorithms that are clear, accessible for everyone to get. The first steps, of course, are the first point of contact, and if there is any question of EVD or exposure, to direct to the designated single room, maintaining a distance, so no hand-holding as you bring them along the corridor. One parent or carer only to accompany the child. Well adults and other children should be sent home, because often they come in en masse, buggies and a couple of children and everything else. Should an accompanying adult be unwell, and that is an important consideration, then the adult care pathway should be activated and arrangements made to transfer that adult out. The most experienced staff should engage with the family and the child, not the first year SHO. Just on a practical level, we've found it helpful, and Richard Drew, our microbiology colleague in Temple Street, was very helpful in sort of crystallizing this into the different phases for us of the initial triage and suspect case identification, which really should take place in less than 2 hours. Stabilization, resuscitation while awaiting the test results, probably 2 to 12 hours, possibly but rarely extending to 24 hours, because then you're going to have decided this child can track along a normal pathway or has to track into a high-risk pathway, and then transfer out will be arranged. So in the general hospitals, in particular around the country, you're really only preparing for those initial 2 phases and third step, rather than the ongoing care. So triage, and this really is the algorithm just in a step-by-step basis, placed with the carer in a single room, get your buddy, don your PPE, risk assessment according to the algorithms. If there's none, exit. If there is, it's time to contact your lab, your micro, infection control, your ID, and your site manager. Not forgetting to do your normal resuscitation, management of the child, arranging for your labs, and then you're coming to differentiating out, is there really still a query of EVD, or is there another diagnosis, and can EVD be safely excluded? And for the cases that we've had so far, it was really, for some of them, it was even before the issue of getting an EVD test that was able to be sorted out. And even though there were only few cases, and in fact I think we had 2 or 3 in Temple Street, a couple in Crumlin, the first one took a little longer time. By the second one, all of those initial labs were back within 2 hours of the child hitting the ED, and you were able to progress on. Sometimes it will happen that you need that EVD test in order to exclude infection, even if it might happen that you have, for example, a malaria back that's positive, but the child might be sicker than you expect or not responding as quickly as you'd like, and you need to get it in order to allow the child to be handled in the normal format. And in that case, you're contacting the NVRL and arranging for the PCR test to be done. If by chance we get a positive Ebola virus test, or if, notwithstanding or not waiting for a test result, there truly is a high-risk situation, of course, then we'll be on to dealing with transferring the child out to an appropriate isolation facility and contacting the NIU. To aid with those steps, in preparation is the Paediatric Ebola Acute Care Pathway, a little more detailed than the adult one, really going into step to step what you need to bring into the room with you, what to think about, and that should be forthcoming in due course. The issues for it, and not to gloss over the problems that are to hand, is that all pathways are leading to one place, which is the NIU. The NIU is in an adult hospital, and the Mater are graciously offering that facility for paediatric patients. The problem is it hasn't been resourced or staffed to deal with children, and so there is a need for paediatric consultants, for nursing, for NCHDs at the most basic level of transfer of a child to the NIU. And as you've adequately heard, there is need for all that staffing to go undergo training to be safe to work in the facility and to have their competencies maintained by weekly updates. That is a huge drain on resources because there just simply isn't that capacity within the existing paediatric network. So we are trying to deal with that and trying to develop volunteer rosters for consultants and for NCHDs and nursing. But the other issue is that for some of these children, critical care will be necessary. And as you've heard, early critical care for someone who is deteriorating will be essential to the management. Now, I don't know how many of you are aware of the fact, but there are only 3 pediatric intensivists in this country. There are 2 pediatric ICUs in the city, which also cater for all the cardiac patients, neurosurgical patients. So it's not to say that we're not all working to get this done. We don't have it sorted at every detail yet, but those are the kind of obstacles that we're working with. In the very long term, there's need for paediatric NIU, and that will be hopefully incorporated within the new children's hospital, but that is the long term. So in the interim, there are a number of possibilities. It might be possible for the development of a modular paediatric isolation unit with adjacency to an existing paediatric ICU, which would facilitate that cover of staff. It has even been speculated that maybe we'll have to evacuate children out of the country to where the facilities might be provided, but I certainly hope it won't come to that. Pediatric care for EVD children at the moment we are working towards its delivery within the NIU, recognizing our current limitations, but hoping that we can bring the additional resources that are needed, that we can give the same assurances that we're able to provide for adult patients for children. And we're very, very grateful to the willingness of the NIU to adopt us in this crisis, as it were, and to offer training to us. And we are very appreciative of that and want to take it up. But we have to recognize that there's a lot of shortfall there that we also need to work on so that we can actually make it viable. So in conclusion, key is early identification, ask the travel history. Have to remember, it is a low risk of transmission in the early stages, and there are several possible scenarios, but not all of these can be anticipated. But hopefully, with all this kind of education, we'll be able to inform ourselves so we can make good judgments at the time if something unexpected turns up. Expertise is developing and is available at the end of a phone. And I will quote Karina, who chaired earlier this morning, who quoted Joe Schmidt, who has had great success recently with our Irish rugby team, in that preparation is a continuum. And I am very conscious that I'm standing here not with the finished product, but it is to say that we are in the middle and we are working very hard and hope to be able to give the support around the country that we appreciate that you will need. And clearly there is more undoubtedly to follow. Thank you.